Well, a warm welcome to this talk, and as always, a welcome back to Professor Robert Clancy. Robert, thank you for joining us again this evening.
As always, John, a great pleasure.
And of course, it's this evening for me, and it's this morning for you. In fact, it's tomorrow morning for you, but this is what happens when you live on the wrong side of the world.
I think it's probably the only way we're ahead of you, John.
I'm sure there's a few others. Right, Robert, what I want to talk about now is pathogenesis of COVID-19 with a particular emphasis we're starting to look at now on long COVID, because we do know that this is, unfortunately, becoming quite a common problem, this post-pandemic period syndrome. So the first question I want to ask is about mucosal immunity. This is the immunity that you've taught us about a few times in the upper respiratory tract. Is it particularly important in COVID, do you think?
Yes, we have talked about this in different ways, but not as directly. The important thing about mucosal immunity is it's that type of immunity that handles bacteria, virus, or anything else that impinges on the mucosal surfaces. That means that anything coming from the outside world is either breathed in or eaten, and it's going to hit a respiratory tract mucosa or the gut. Now, you can imagine the myriad of pathogens, bacteria, viruses that are acting and impinging on those mucosal surfaces. And it's very, very different to inside the body, which is pristine clean. It's sterile. You do not want any bacteria or virus, as much as possible, floating around inside you. And so therefore the body has adapted the way it protects itself against inhaled bacteria or viruses by developing a particular type of immune response, which is very relevant to understanding the pathogenesis of COVID and also the pathogenesis of the effect of vaccination. So what is the difference? Well, there are a lot of differences, but the prime difference is that the dominant response that occurs to prevent huge inflammatory response to every bacteria, every virus, is one of downregulation. The idea is not to become active and specifically vigorous in the way it might eliminate a bacteria that leaks into the bloodstream, the systemic immune response, where you get a very vigorous, active immune response ensuring that the inside of the body is sterile. What you actually get at a mucosal surface is a much more subtle control system so that you protect, but at the same time you've got to let gases go across the mucosa. You've got to let food particles get absorbed into the body. It's an incredibly complicated system that really hasn't been given, certainly in the COVID world, any or much attention. And so what happens with mucosal immunology is that when you breathe in a coronavirus, a COVID virus, it stimulates a positive and a negative response. And always the outcome is the balance between the positive and the negative. And this negative is not just in the mucosa, but it goes throughout the body. So if in the lymph nodes, for example, which would be receiving a COVID vaccine, you get the antigen or the messenger RNA making antigen, then the response that you're going to get in the bloodstream will be the balance between the positive and the negative. And the more you stimulate these systems, the more the body moves towards net negativity. And this is the point that's been completely missed in the vaccine issue of COVID. It's not rocket science, it's not new, it's been there all the time. But I think the people who are involved either do not seem to understand these simple basic immunological concepts, or they just seem to accept that in the past we've vaccinated once a year and everything is okay. The change has been that because the vaccine predictably hasn't worked that well, in COVID. The idea is, oh, let's give more vaccine, let's give more vaccine. But of course, what you're doing is moving more the seesaw towards negativity, and that's exactly what we're seeing. And the great sadness is that ultimately you start getting a negative net effect, which promotes infection and promotes more severe infection. Does that make sense to you, John?
It does, and as well as that, the natural infection which lands on the mucous membranes is going to stimulate the specific mucosal immunity. And I think that brings me on to my next question,
Yes,
Robert.
yes.
Yeah, the difference between immunoglobulin type G and immunoglobulin type A. What is the difference, and what parts of the body are these responsible for immunity in?
The IgG and IgA are the marker antibodies for IgA for mucosal immunology and IgG for systemic immunology. And so these are two similar looking immunoglobulin antibody molecules, but they behave in very different ways. The IgG antibody, which is the dominant antibody in the bloodstream, the dominant antibody that reflects systemic immune response, and the dominant antibody that you get when you inject a vaccine. It's the dominant antibody when a COVID infection gets out of the mucosal compartment into the gas exchange part of the lung. And this is the antibody that has to work quickly. It has to keep the inside of the body sterile, so it recruits a powerful army of innate immune mechanisms. For example, it makes cells that phagocytose or take up particles like bacteria and virus work more effectively. It activates amplification mechanisms that work on the basis of cascading systems like complement. Now, complement is a very old term that was found by Pasteur and the people working back in the 19th century, where they found that the IgG antibody, not that they knew it was an IgG antibody, needed to have various components of the blood to work most effectively. So if you think about it, the IgG molecule is like the general of an army, where the complement system, the phagocytes, the cells that take up bacteria or viruses, they're the foot soldiers. So the general's making a decision, telling the foot soldiers to get on with this and give me sterilizing immunity. Now, when we come to the mucosal surfaces, you don't want that, because if you tell the foot soldiers to blow up what's going on, you're going to blow up the whole lining of your lung and the whole lining of your gut. So the IgA system, which was really only identified back in the 1960s by a chap called Heremans, who then another person in Boston worked out that, and then Buffalo, New York, worked out that a different type of antibody worked in the secretions of the respiratory tract and the gut. And this was the IgA molecule. And the big difference is that the IgA molecule does not activate foot soldiers. And so you've got an IgG molecule dependent on its foot soldiers to give you a sterilizing immunity. You've got a much more subtle IgA system that does not what we call fix complement or activate complement. It doesn't make the phagocytes work more effectively. What it does, it can have subtle effects on the absorption and uptake of bacteria, viruses, and in fact has other more subtle impact. But in the mucosal surfaces, the T lymphocyte, remember we've got B lymphocytes making antibody and T lymphocytes having their own effect. The T lymphocytes have been shown to be probably more important, because you can be born without any IgA. My closest colleague, who I worked with for 30 years, he actually had no IgA, and seeing we ran a mucosal immunology research institute, it was always a matter of some joke, but he never got too many respiratory tract infections. But he had good T cells. And so the IgA molecule's been very important in identifying this discrete, separate mucosal immune compartment. And of course, it does also have important effects. But it's probably the T cell that becomes most important in controlling the infections occurring at mucosal sites.
So the IgA, like the IgM, they can both neutralize antigens. They can both agglutinate antigens prior to phagocytosis, but the difference is the IgA doesn't stimulate other systems within the body and within the blood, whereas the IgM does stimulate these other systems to bolster the innate immune response.
Yes.
Amazing you
that's true.
survived for that IgA. That's incredible.
Yeah, another important thing about IgA is that it's what's called a high affinity antibody. So if you've got a virus and you've got a bit of IgG and a bit of IgA antibody, and you don't want the IgG to excite a big inflammatory response in the mucosa, and you've got a little bit of IgG, the IgA will have preferential go at binding to that virus, and so it can block the IgG. And so you've got this subtle interaction between the, if you like, the flag bearers of the two systems, and the mucosal one always wins out.
That is really interesting. So that means that potentially if you're exposed to a natural virus, whether it's influenza, COVID, whatever it happens to be, that's going to stimulate the IgA. But the IgA, in a sense, will outcompete the IgG. So having the natural immunity, the IgA from the natural immunity, could actually have an overall anti-inflammatory effect.
Absolutely. It's an anti-inflammatory antibody.
Yeah, I didn't know that. Thank you. That's really quite interesting. And the T lymphocytes in the mucosal compartment, they will they will be T cytotoxic cells. They will directly kill.
Well, they can. The most important T cells, and we're talking about the respiratory tract because that, of course, is the target for an inhaled virus like COVID. The airways are very clever. They worked out very early in the piece that what they're about is exchanging gases. I mean, the lung is there to take oxygen in and carbon dioxide out. It doesn't want to get messed up with all the cell divisions and all the stuff that goes on in generating the effector mechanisms of immunity. And so what they've done is they've parked that in the gut. And the way in which you develop this immune response in the airways is actually swallowing the contents of the airways, which would include the microbiome, the bacteria and viruses that are around. And that goes down through the gut. And there's a little package of cells which is embedded in the small bowel called the Peyer's patches. Now, when I was a student, it drove us crazy that we had to learn about Peyer's patches because no one had any idea what they did. Well, now, of course, we do know what they do. They're the factory for making the T cells and IgA antibody-making cells important for mucosal protection, be it in the lungs or be it in the gut. And so what happens then is that these cells which are stimulated in the Peyer's patch against, say, a coronavirus or a COVID virus, go through the bloodstream, and they've got little postage stamps on them that say, take me to the mucosa. And so you get this homing, the specific homing of these cells. And I was part of the group under John Bienenstock 50 years ago, a long time ago, that first described what we call now the common mucosal system. And when I came back to Australia, we started looking at what the cells, whether they're T cells or B cells. And we were surprised to find that the cells that are most protective are not B cells making antibody, but rather T cells. And this was back in the 80s and 90s when it was very, very controversial because it didn't make sense. And we later found, when we discovered Th17 cells, that these were actually a particular type of T cell called the Th17 cell, which is a very popular cell these days in terms of causing autoimmunity and protection of mucosal surfaces. So it's this particular type of T cell that has the capacity to mobilise and activate the white cells and the phagocytes that are so important in maintaining control of the microbiome or the bacteria and viruses that bathe the mucosal surfaces.
So these T cells are almost like a conductor of the mucosal respiratory orchestra.
Yes, they are. I hadn't thought of it that way, but they certainly are.
Amazing.
They're the prime movers.
So these T17s, they're different to CD4s, they're different to CD8s. It's a completely different class of lymphocyte.
Yes, they've got a particular role. I mean, we now know there are a whole range of these different. Initially, it was just T cells, and then it was Th1 and Th2, and now it's Th17, and they've all got their own particular little packages of activity. And then on the other hand, you've got the CD. They're all CD4 cells, and they have
helper cells.
Numbers,
yeah.
4, 8, 17. Yeah, they are. And then you've got the CD8 cells, which are the cytotoxic cells, which are up the other class, which actually kill cells containing viruses, for example, or cancer cells.
Right. So these T17s are a subset of the CD4s.
Exactly.
The helper cells. Got it. But they labelled they go to the mucosal surfaces and they help the immune response in the mucosal surface.
Yes.
You know, you learn about the body for 40 years and then you just learn there's another complete layer of complexity you'd never dreamed existed. It's kind of depressing in a way, but it's also wonderful. So keeps us going in retirement.
Yeah. That's right. We've talked about this before, but if you look at the immune system, as you can look at any other system in the body, and you start off by looking at a particular molecule that does something, the mind boggles and you get nowhere. And I think this is one of the sadnesses that I'm noticing, particularly as I'm now very involved in developing a research institute, recruiting young people to come in and do PhDs, is that it's very important that these people come in and don't suddenly focus on the molecule of the day, because then you miss that big picture, because it's still the big picture that, and I think this has been the big problem in COVID, that people have been lost in the technology of messenger RNA without actually saying, well, wait a second, what is the big picture here?
Absolutely, I couldn't agree more. You need that basic, general, broad understanding, and then by all means specialise after
and then
that.
You can run down on cell, the molecule, the gene.
Yeah. You don't want to lose sight of the wood for the trees.
No.
In an infectious disease, what is the effect of antigen excess? Indeed, what is antigen excess?
Yeah, I think I used that term in the article that you're getting the questions from. I was trying to think of a neat, smart way to talk about outcomes of infection and in terms of the relationship that an infective pathogen, bad virus, bad bacteria, has in its relationship to the way the body responds. And in fact, most people look at this as what we call a host-parasite relationship, the relationship between the host, the immune response, and the parasite, the virus or bacteria that is coming in. And what I've tried to do here is say that if the antigen, the virus, escapes from the bronchus, and that's really what makes COVID-19 a bad coronavirus. It's got the capacity to not stay where coronaviruses should stay. It gets into the gas exchange apparatus and immediately engages the systemic immune response, which is the type of immune response required, because you do, again, teleologically, you want the gas exchange apparatus to be completely sterile. That's where the gases go in and out. That's terribly important. And so once you get there, you've got the virus antigen and the IgG antibody. Now, if you've got a lot of virus, a lot of antigen, it's going to overwhelm any antibody and cause basically viral pneumonia and that puts people in hospital and can kill people. If you've got a lot of antibody, that's going to stop the virus. So it's all about a balance between the antigen and the antibody. I mean, that's putting it very simply, but in essence, that's what I mean by antigen excess or antibody excess. It's about the ratio of the pathogen and the antibody against it. And of course, with vaccines, the aim is to increase the IgG antibody so that you have protection by having antibody excess. More antibody than you have antigen, if you like, and you have the seesaw built or tilted towards protection rather than disease progression.
Yeah, that's good. So antibody excess will build up over time and that would be protective.
Yes, and you have natural antibody from all the coronaviruses that you've been exposed to over many years, or you've had COVID in the past, or you have a boosted amount of antibody by injecting. But again, we know the positives and negatives of that story.
Mm-hmm. I want to move on to long COVID, Robert. How common is this in your understanding and reading at the moment?
Well, it's a very good question. If you look at the literature, when we had a very nasty form of COVID, people were talking about up to 20% of people who were hospitalised would get long COVID. But there was a lot of confusion. The main confusion was that individuals who were getting sequelae as a result of getting COVID infection were called long COVID cases. And initially, there was a great mix. On one hand, you had people who had damage to their lung, they were breathless or systemic features, and they were all grouped together. I think as we've learnt more about this, it's becoming quite clear that we're taking out the structural changes and we're left with essentially a condition that is probably identical to what we've been seeing for many years as chronic fatigue syndrome. It's an area that I've been very interested in for a long time. The chronic fatigue syndrome is classically seen in the context of what we call infectious mononucleosis or glandular fever. And many people, in fact 90% of the population, has actually been exposed to the Epstein-Barr virus or EBV, which is the cause of glandular fever. And I think the point that I've tried to make is that we can learn a lot about long COVID by understanding as much as we can about the classic cause of chronic fatigue syndrome. To answer your question, there's no doubt we're seeing, I think there are two things that are changing with the clinical patterns of long COVID. The first is that we're seeing much less of it. There's little doubt that more severe disease is more likely to create long COVID, and we're seeing much less more severe disease. And the second is we're starting to see, I've certainly seen, and I don't see a great number of patients these days, but I'm certainly seeing some very interesting patients who are developing chronic fatigue syndrome following multiple vaccinations. So the issue now is what on earth is going on? What can we learn from everything we've been doing in terms of understanding chronic fatigue syndrome? Is there some messages? Are there hypotheses that we can develop and test?
So one thing I'm unclear about is that the chronic fatigue that we're seeing after COVID infection, yes, the chronic fatigue, the long COVID, whatever we want to call it, it is more common after severe illness. So there was more cases in the Wuhan wave, the Alpha wave, the Delta wave, and we're getting fewer cases in the Omicron era. But is it, and for example, if someone's been in intensive care for whatever reason, they can have sequelae for some time. Is it the fact that these people have been sick, or is it a specific effect of the virus?
Well, jumping ahead, my view is that all of these chronic fatigue illnesses that can follow a number of different virus infections, the Epstein-Barr virus, Ross River virus. We're seeing it occasionally in other conditions. Essentially relates to a persistence of the antigen in the body, and that occurs because of very subtle immunological defects. And I'll just go back to the chronic fatigue syndrome that I would see in my clinics. That some years ago, I said to my registrar, look, let's look at the last 150 cases. I mean, this was so common. Let's look at 150 cases referred to us to investigate with the diagnosis of chronic fatigue. Now, half of those cases, absolutely half of those cases, had misdiagnoses by the referring doctor. They had underactive thyroid disease, they had autoimmune disease. It's just that it became such a common problem that the family doctor would say, oh, you've got chronic fatigue, you better go to see a clinical immunologist. And it used to drive us crazy because that was the dominant, for some time, we were seeing so many of these unfortunate people. But the other half are people who didn't fit. Now, there were two groups in this other half. There were some people who are actually using fatigue as a way of manipulating their environment. There's no question that this does exist. But I used to have a key question that I would ask. And I'm not being a sexist here, but most of the patients who get this are women. And I'd say, what does your husband or your partner feel about this? Now, I can assure you that if you're in a partnership and you've got a chronic fatigue illness, the partner's not very happy about it. But there is that occasional person would say, oh, he's so understanding, or occasionally she is so understanding. And that, I've probably given away all my secrets now, but that was a very important question to ask. But let's get back to the real post-viral fatigue illnesses. We got very interested in this because I noticed that in a great number of the patients I was seeing, usually often teenage kids under great stress of exams, we call the final exam at schools the HSC, and I just used to call this the HSC disease because every year I'd get to see another dozen young kids who were under great stresses, and they would get large lymph nodes, sore throats, and if you measured high levels of Epstein-Barr virus in their secretions, and we could quite effectively treat some of these patients using what we call a herpes zoster pack of acyclovir, which is a high level of acyclovir. But what we found in a lot of these people with the chronic fatigue was that they never made a proper immune response to the virus. And this is what I suspect is exactly happening in the people with post-COVID or long COVID syndrome. What we found, if you mentioned actually the IgM antibody molecule a little while ago, if you get a glandular fever, Epstein-Barr virus infection, your body immediately makes an antibody molecule called IgM. It's not a particularly good, high-quality antibody, so it says, we'll switch and we'll see if you've got, and we'll start making the IgG molecule, and we'll make progressively better ones, higher affinity, better binding capacity. And so if you come along and see a doctor when you've got the sore throat and you've got infectious mononucleosis or glandular fever, what the doctor does, he asks for an IgM antibody to see if you've got the early antibody, which is diagnostic of the acute syndrome of the day. But if you come back 6 months later and you've got symptoms, there should be no IgM because it's been completely replaced by this better IgG antibody molecule. What you find in many of these patients is, and this, I've had many doctors ring up and say, look, I can't understand it. This patient's got IgM and IgG. And so you've got this confused body's capacity to respond to the virus. And so they have IgM and IgG positive. And it is very confusing, except you stand back and say, well, what does this mean? And of course, what it means is that that particular individual is not making a clearance containing IgG high quality, high affinity IgG antibody response. Because what happens with the Epstein-Barr virus is that it gets incorporated into your own DNA and it's there for life. And the body puts a wall around those cells in the throat so that you don't get the Epstein-Barr virus coming out. And what happens in chronic fatigue is under stress of different types, you get the Epstein-Barr virus popping out because it's not being contained. And it's not being contained because the immune containment of the virus is defective. And we see this in a very crude way by measuring two things, measuring the IgM and IgG antibody and find there has not been a transition to a highly competent immune response. And we measure the IgG subclasses because IgG is made up of 4 subclasses. This is becoming also very important in understanding COVID because individuals are finding that the IgG4, which is usually a very small amount and more related to allergy issues, is going up quite high in some of these patients with recurrent vaccination. That's another story. But what you do find is in people with chronic fatigue and some of these patients with long COVID is they are lacking high levels of subclasses. And so you've got 2 clues that this is exactly what is happening in any of these post-viral fatigue illnesses.
Does the ongoing presence of IgM indicate the ongoing existence of acute infection or the presence of an ongoing antigen? Exactly.
What the fact that you're not transitioning to high quality clearing immune responses means that the antigen is not being eliminated. It's being persistent. And this is really the most exciting thing. Just 2 days ago, I noticed that a study's been done in COVID, long COVID patients, where they're finding up to 12 months after they've had this long COVID, long period of time, they're actually finding the messenger RNA that is coding for the spike protein and the presence of spike protein. Both of these are still present in the blood of about 1/3 of the individuals with long COVID, but not in people who have not got long COVID. Now, it's a long way to go, but all of a sudden we're starting to find little tiny snippets of information that are lining up chronic fatigue syndromes, the one that we've been seeing particularly over the last 20 years, with what we're starting to see now in COVID. And the way we looked at this, because we got very interested in chronic fatigue, we wanted a model system that we could look at, and we started looking at athletes, elite athletes, who were not performing to their maximum capacity. They had impaired performance, which we identified for them as a chronic fatigue illness, although I think all of those people I see with chronic fatigue would die to have that level that they've just dropped 1 second in their 100-metre sprint. but so we looked at the Institute of Sport for a number of years, and we got a lot of insight into understanding this process.
Mm-hmm. So that's really quite alarming, really. A significant subset of long COVID patients are still producing spike protein or presumably complete viral antibodies at 12 months. So presumably they're producing antibodies to nucleocapsid protein and envelope protein as well as spike protein.
Well, I don't know the answer to that because I don't think that was looked at in the study that I saw. But they certainly would have that nucleocapsid antibody in their serum. They'd have the antibody. I think what has been specifically looked at has been the spike protein, which, given that it's unlikely to be by itself after the viral infection, you'd expect the full virus to be there. I think what is really fascinating is that the little snippets of inflammation, low levels of inflammation that's occurring as a result of the host-parasite relationship that is persisting. We know this can have the cognitive defects, the brain fog that is so characteristic in the brain. Fatigue is something that goes with any chronic inflammatory circumstance. And the whole picture, to me at least, is becoming clear. Let me tell you about a patient that I saw that I think is, I don't know if this is going to be the total answer. This was a fairly high-ranking administrator in the government in Australia who was bedridden with classic post-infection fatigue following not infection but repeated vaccination, which is part of his mandated story. He'd had something like 4 or 5 over a period of 18 months. And he developed a classic COVID, or a classic chronic fatigue illness. Now, he was bedridden. He couldn't work. We thought, well, maybe this is because he's got persistent spike protein, that we know this occurs after people with multiple vaccines. We know they get a subtle immune defect because they're down-regulating, they're turning off their immune response. So we treated him actually with high-dose ivermectin. We did this not because we wanted to affect anything on the virus, but because of very, very important studies that have now been done, including peer-reviewed studies, showing that if you do treat, that ivermectin has this capacity to block the effect of spike protein on red cells, hemagglutinating, and presumably block the effect on damaging the lining cells, endothelium. Anyway, this is interesting because he was a person not with infection. He did not have nucleocapsid antibodies, so he'd never had, as best we knew, viral infection, but he did have multiple vaccines, and he developed the post-vaccine fatigue illness, which other people now are also describing. We don't know how often it occurs, but it certainly does occur. And he got a dramatic improvement. I saw him 3 weeks later, and he was back at work. Now, this just does not happen with people with this level of morbidity from chronic fatigue. It was not quite Lazarus-like, but it was certainly a dramatic improvement. Now, I'm expecting to see him again in the next couple of weeks, and the question really will be, well, because he stopped taking, we only had one 12-day course of the ivermectin, what happens now? Does he relapse because he's still making the spike protein? So it's sort of much an ongoing story, but I think it's the type of observation that we need to make, because it gives us a little bits of insight into what might be going on in these patients.
I mean, my understanding is that ivermectin will actually stick to, it's adherent to part of the spike protein. And that makes the end of the spike protein knobbly, and it will no longer fit into the keyhole. It will no longer fit into the receptor.
That's the current story, yes.
Can I just throw out a challenge there,
irrespective
Robert?
of
irrespective of where the spike
protein irrespective
comes
of what you believe in terms of treating acute infection.
No, it's a biochemical fact that ivermectin sticks to spike protein. I don't think that's contentious. I just challenge you on?
It's quite well established.
Yeah, can I challenge you on one point? You said this chap did not have COVID infection because he didn't have nucleocapsid antibodies. Could it be that he had COVID infection, but the nucleocapsid antibodies are dropped below the sensitivity of your test to detect it?
Yes, actually what I said is, as best we knew, he hadn't had the infection, because you're absolutely right. He could well have had the infection. And I think that if I was setting up a major research program looking at this, I'd be very interested in the people who do get chronic fatigue. Are they people who have both the vaccine, how much vaccine, and the infection? Because if the idea of spike protein is critical, then it doesn't really matter how you get the spike protein. If it's persistent, if there's some subtle defects in the clearance of that spike, or for some reason the messenger RNA persists, we know. I just thought of this. Maybe it's heretical, but we know that messenger RNA can undergo reverse transcriptase and get into DNA. What has to be looked at, I think, is DNA now creating the production of spike protein in some of these patients.
So it's possible that DNA makes RNA makes protein. This is the central dogma of genetics. If that information had somehow got into the DNA, it would carry on making spike protein indefinitely.
Exactly. And we do know that in other chronic fatigue illnesses like Epstein-Barr, there is in fact integration of the viral DNA into the host DNA.
Does the Epstein-Barr virus carry its own reverse transcriptase, Robert, or does it use the cell's reverse transcriptase?
No, it doesn't have to, because it's a DNA virus.
Ah, right. So the DNA will actually go. It will actually merge with the body's own DNA without reverse transcriptase.
Exactly. With an RNA, with messenger RNA, with an RNA virus, it has to be reverse transcripted back into DNA. And we do know that cells can do this. We don't know the extent, and we don't know the impact of outcome.
Amazing. I didn't know that. So if you look at my cells now, my somatic cells, they could actually be carrying DNA from some of the thousands of viral infections I've been exposed to over my lifetime.
And I hate to say it, John, but it does. It almost certainly does.
That's incredible. Yeah. I mean, it's not surprising, because something like 9% of the human genome is viral origin, isn't it? It's just that they've happened to get into the
absolutely,
into the
over
germline
generations
cells.
We're accumulating.
I wonder what would look like if we had no viral DNA in us, Robert. Do you think maybe we'd have more hair?
I don't know what you'd look like, John. But hard to know.
Yeah, incredible. No, you learn something every time. Quite incredible. So this idea of defective immune clearance. So at the moment, clinically, when you look at a patient, you can't say whether that is a chronic fatigue from COVID or a chronic fatigue from multiple vaccination. Clinically, it presents as the same.
That I believe is the story that's evolving. Yes, certainly.
So really, to differentiate,
because I only see people with.
Sorry.
No, go on. I only see people who have got a problem, so I don't.
Yeah.
I don't see everybody who's vaccinated.
Yeah. I mean, I suppose, yeah, of course. The differentiation here would be really, I suppose, if we could have immunohistochemistry and immunohisto analysis of some sort, and work out whether these patients did have only spike protein, or whether they had other viral components. If it was only spike protein, and of course it would be quite possible to do genetics on that, because the spike protein from the vaccine is different from the spike protein on the virus to an extent. So the technology is there to do this analysis. It'd be interesting.
And it's been done. Right. I mean, we know from particularly the German pathologists who have done, and there's some now from America. People are now. It's not a difficult thing to do. You can do immunochemistry on the sections if they're biopsies or post-mortem samples, and what they're finding in people who are dying in the community. About 15% of them actually have expression of spike protein in cells in the heart and the brain, surrounded by T lymphocytes, which are attacking that as a foreign antigen. So we know that there's persistence, and we know that persistence can occur for a long period of time, certainly many months.
Taking those German studies, there's been spike protein discovered in the myocardium of patients that died from spontaneous cardiac events, sadly. There's been spike protein discovered in post-mortem brain samples as well. What people have said to me is the fact that you've discovered spike protein on its own without nucleocapsid protein or any other viral proteins doesn't necessarily mean that that spike protein got there as a result of the vaccine. But I think it does. I think it does. I mean, is there any plausible mechanism whereby a virus could infect, say, the myocardium or the brain, and all of that virus could be successfully eliminated? 100% of that virus could be eliminated, apart from one particular protein expression of that virus. That doesn't sound viable to me.
Does that totally sound viable to you? Here. No, it makes no sense to me that and this is what has been shown, is that they use specific antibodies against nuclear capsid antigens and others against spike, and they're only finding the spike positive. I mean, the whole purpose of this is to show that you're only getting expression of one part of the virus, and it makes no logical sense to me that you would suddenly not get a response to the 95 or 90% of the virus that's infecting, if that's in fact causing the spike protein to be expressed. Doesn't make sense.
No, I agree. So isolated spike protein is an indication of vaccine in the absence of infection in a particular tissue. I'm happy to run with that hypothesis.
That's what most people believe. Yes.
Yeah. Good. I want to go on and talk about vaccines a bit, Robert, if that's okay. What can we learn about systemic vaccines not preventing transmission from previous knowledge of influenza vaccination? So we're giving systemic, we're not giving mucosal compartment COVID vaccines. They're entirely systemic. They're being injected. But we've known about influenza immunology for 100 years or well over 100 years. So what can we learn about and we know now that the COVID vaccines don't stop transmission, or essentially don't stop transmission. Is that also true for influenza?
I think yes, I think it is. It's funnily enough, it's probably been less studied in a sense than COVID, because COVID has been such a focus in the last couple of years that everyone is looking at COVID. What we've learnt, and we should have learnt a lot more from influenza vaccination, is that you get relatively poor prevention of actually getting mild infection, asymptomatic infection. A little bit, but not much. But the idea has always been, as with COVID, that you have IgG and it will stop the nasty flu virus creating problems outside of the airways. So I think the story that we have with COVID is the same as with flu. It's a little murkier in terms of the databases, because other issues have been more at the fore. I mean, the big focus in flu is to has been a focus on serum antibodies to check that you've got immunity against the current circulating type of influenza virus, that you get drift, which we've talked about before, of antigens, and so each year it's a slightly different virus, and you've got to bring up a slightly different vaccine. I mean, it's interesting, isn't it? Because it's not a great vaccine, and the interesting point, there was a remarkable woman in America called, remarkable woman who, back in the early 2000s, looked at the mortality of veterans that had been vaccinated against flu. And for a couple of months, the veterans had a lower mortality by about 10%. This is really quite interesting, because it's quite the opposite with if you take a large population and see a mortality drop of 10%, because there appeared to be some non-specific protection against various things. And it was a beautifully done study. Kristen showed that there was this high level protection against all sorts of heart attacks, everything in that population. But the mortality protection against influenza, it's been demonstrated over and over again, but it's pretty much similar to what you see with COVID. It's not incredibly dramatic, but it's sort of better than nothing. But it's not great.
There's this strange protection against pretty well all-cause mortality for about 8 weeks after the influenza vaccine.
Yeah, exactly, which is quite, one of the topics of great interest around the world at the moment is this increase in mortality that correlates with the vaccine programs in COVID. And it's quite the opposite in flu, which no one seems to have really picked up on. But it's an important thing to keep in mind.
But the influenza protection only lasted for a couple of months. It was pretty short. The protection against
yes, it was
death.
only for a couple of months. Exactly. Yeah, exactly. In fact, it got transmitted. Giving away some secrets, there are sporting teams around the world going to the Olympics, and they would all get their influenza vaccine, not to stop them getting influenza, but because it thought it had a non-specific protection effect against different viruses. I'm not sure if they still do that.
I don't know if that's allowed or not. It probably is, but interesting.
I'm not sure it's allowed.
Right. Here's a question. Was it initially reasonable to think that the vaccines as used could protect against severe COVID, thinking about the COVID vaccines? Going back when we didn't know about the side effects of vaccines.
Yeah. No, I think that it made a lot of sense that you could stimulate antibody that could prevent or reduce the impact of escaped COVID virus into the gas exchange apparatus and further on through the rest of the body. And I think if you look at all the data in those early Wuhan virus and the Delta virus, I think the data cumulative suggests to me that yes, there was protection against severe disease.
So that in the initial stages, at least, in the initial stages, at least, the COVID vaccines did prevent some deaths from severe COVID.
Yes, I'm perfectly happy to accept that data. I think that what happened with time was that the virus changed, the immune status of individuals changed, and collectively you put those together, and you got a circumstance which now there's certainly evidence suggesting that the person with multiple vaccines may be more prone to developing serious disease. And that's not an isolated observation. It's occurring in a number of different countries.
That was then and now is now. So I think what you're talking about there, Robert, is the stimulation of the suppressor cells and the production of the IgG4 cells, which are immunosuppressive.
Sure, yeah. Certainly the suppressor cells, yeah. I think the IgG4 story is a fascinating one. That's exactly what you get when you inject people with lots of antigen to stop them getting allergies for house dust mite or pollens, which they're inhaling into their airways. Their IgG4 goes up, and there are many allergists around the world who would like to think that the IgG4 is a blocking antibody and stops the inflammatory effect, the protective effect of other subclasses of IgG. Other people think that's probably not the case. It's more just an indicator that you're getting a switch towards down-regulation as opposed to up-regulation.
It wouldn't surprise me at all because, as you say, throughout we always have these checks and balances, don't we? So to have a particular IgG4 which did have a blocking effect, an inhibitory effect, wouldn't be at all surprising.
2,000 years.
No, we don't want to be having allergic reactions to peanuts and things, do we? I mean, that would be...
Well, of course, there's a big interest now with, feeding peanuts so that they develop the suppressor mechanisms. And the whole, the pediatricians, the pediatric clinical immunologists, food allergies is the bread and butter of their of their job.
I won't get
Certainly
distracted into
it's
this,
the
but
bulk of the wood.
for 20 years I taught lactating mums not to eat peanuts, and I told them not to give their kids peanut butter till they were 5 years old, and now it turns out I was telling them exactly the wrong thing. And it wasn't just me being thick
It'll
for
all
a
go
change.
back
It was
again.
that was the official government guidelines.
That's right. Now
Yeah.
well, it's a bit like having lots of COVID vaccines, isn't it?
It is. It is very much so. So I think that's covered the question there. What is negative immunity? I think that's kind of a negative immunity we've been talking about, Robert, isn't it?
Yes, we have. It's where you obviously get a balance going towards promotion rather than protection.
And that negative immunity is possible as a result of multiple vaccinations. That's not a contentious statement, is it?
And that's been well demonstrated.
Yeah. Is there any evidence for negative immunity in the hospital admission data in Australia?
Well, it's most countries, when they start getting figures that don't fit the narrative, stop giving out their figures. I'm not sure if it's ever come back in the United Kingdom, but I know that there was a lot of interest in November of last year when suddenly the data that was coming out and sort of, because it's never analysed by the official party, so it gets analysed by either rank amateurs or people interested. And when the analysis was done by various people, they found that basically nobody in hospital in New South Wales was unvaccinated. In other words, everyone was multiply vaccinated, which sort of fits the idea that you're going to get more severe disease with more vaccine. And I think we talked one other time about the pattern of morbidity and mortality in Australia, where we had very little mortality up till November of 21. So for 2 years, we had very few people dying. And then, of course, we got away from our lockdowns, opened up our borders, and we started our booster vaccine programs. And it was then that we started seeing not just a lot of people getting infections, but a lot of people going to hospital, and most of our mortality data came in the 8, 9, 10 months that followed that.
How is the dose of spike protein produced in the body regulated? Could this affect could this affect our positive or negative clinical outcomes? So we give a very precise dose of vaccine. How is the amount of antigen produced regulated, if indeed it is regulated?
Well, I think your last comment is accurate, that you don't have regulation. The idea that was initially promoted was that you put messenger RNA into the body, it would only go to your local lymph nodes, and then it would make a burst of antigen and then disappear. Well, of course, that is not the case. We know that the messenger RNA can continue. I mentioned the data that I read came out just a couple of days ago, showing that the messenger RNA can still be seen in people with long COVID, about a third of them, months or a year or so after they have their infection. So you're not actually, the regulation of the antigen production depends on the elimination and prevention of more messenger RNA being produced. So you're not getting the same type of immune regulation. It's more a genetic regulation that's involved. Very different process.
I've just
And
thought
that's the problem. You're getting unregulated amounts of antigen. Yeah.
Yeah. If just so you have the mRNA in the cell, that makes this spike protein which goes onto the surface of the cell. And that sits there on the surface of the cell. Now, once the mRNA has made that spike protein and that spike protein sits on the surface of the cell, how long will that spike protein stay there for before it's chemically denatured by the immune system?
I don't think I don't think we know the answers to those questions. The idea was put that it doesn't stay there very long, it's just expressed and then disappears. Well, that's clearly not the case in many cases.
Yeah, because what I'm trying to get at, Robert, we know there's people with spike protein months and months after the vaccines. Is that because the mRNA is persisting and is still making spike protein? Or is it because the messenger RNA made some spike protein, that then the mRNA somehow disappeared and the spike protein persists? So is it the mRNA that's persisting, or is it the spike protein that's persisting?
No, I think biologically it'd be the messenger RNA that's persisting, not the antigens being renewed, because we know that surface proteins are in a dynamic situation where they're coming and they're going. And we do know that messenger RNA persists. I think the data that's just coming out with these chronic fatigue shows you getting messenger RNA. I think they were talking about 12 months after the infection in that case.
It's very hard to imagine a foreign antigen on a cell surface in the body surviving for more than a few days, I would have thought. Is that?
Yes, I'm sure that would make most sense to me.
What are the main vaccine side effects that you're concerned about now?
Well, the vaccine side effects really fit into maybe three different groups. There's the 1 in 10,000 person who gets anaphylaxis, and that sounds pretty uncommon, but there's a lot of people getting vaccinated. I saw a patient just last week who had an allergic reaction to the first dose with hives and itchy urticaria, and came back for the second, was given the second one, and nearly died from life-threatening anaphylaxis. So it's important to be aware of this, and anyone who is giving the vaccine needs to have adrenaline available for those occasional. I think it's something like about 1 in 10,000 will get that. The second group is the group that probably most concerns me, and that is the production of spike protein on cells, providing a foreign antigen that can be attacked by cytotoxic or CD4 or various types of T lymphocytes. And that seems to be the cause of the morbidity and mortality that we're seeing from myocarditis, brain lesions, and vascular lesions. So that's the thing that concerns me most. And this is the area that got so many red flags that can be and should be really focused on by the authorities to work out how big is this problem and what do we do about it. Because as at other times we've discussed, there are whole industries now beginning using exactly the same methodology and technology. And we're sitting back letting this happen so that every kid is going to be given messenger RNA vaccines without us understanding the potential of damage from that particular side effect. So that's the thing that worries me most.
And I think we do understand quite a bit integration. There, though, Robert. We do understand quite a bit. We know there's going to be some systemic absorption. We know there's going to be systemic distribution of the messenger RNA. We know that's going to get into a multiplicity of cells, vascular endothelial cells in the brain, in the myocardium, in the testes, in the liver, kidney, technically everywhere. We know that those vascular endothelial cells are going to produce surface antigen, regardless of what that surface antigen is. And we know that there's going to be an inflammatory reaction to that surface antigen. So it's pretty worrying.
Yes, of course we know. Yeah, of course we know this. My point is that these are red flags that are not being taken seriously, and that the red flags have to be sorted out before we even think of exposing our children, ourselves, to vaccines that could be devastating when they're probably not even needed. There's not a jot of evidence that these genetically produced antigens and messenger RNA vaccines are any better than the traditional ones. And the only data that I know exists was a comparison for messenger RNA, a small study for flu, compared with the classic split virus antigen vaccine, and there was no difference in terms of antibody production. But we also know that the more you give these messenger RNA vaccines, the more you turn off the immune response, particularly for infections that are coming to us through the airways or the gut. The mind boggles.
I interrupted your train of thought there, Robert. The first one was anaphylaxis that you're worried about. The second one is spike protein. What was the third one?
Systemic antigen production with autoimmune type responses. And the third one, which we know very little about, is the reverse transcriptase, where you're getting the messenger RNA transcribed back into the DNA of the cell, and the potential of that, whether it can be causing cancers later on or across the generation into the germline. No one has even looked seriously at this, although there are at least 3 papers that I'm aware of which has shown that you can actually transcribe. You get this reverse transcription into DNA.
So this is more than a theoretical concern.
Absolutely.
Couple of questions that's brought up in my mind, Robert. Going back to the anaphylaxis idea, if you give an antigen, or in this case the vaccine, this vaccine, if you give it intravenously or via an inadvertent intravascular injection, or you get more rapid systemic absorption, is that going to increase the probability of an anaphylactic reaction?
Absolutely. If you have the anaphylaxis inducing antibody, which is another type of antibody we call the IgE, immunologists love to confuse people. So we've talked about IgA and IgG. Well, there's another one called IgE. That's the one that activates cells called mast cells, which release histamine and various vasoactive amines and products. If you inject something intravenously, or inadvertently it goes intravenously, it immediately combines with the circulating antibodies and particularly combines with the IgE, which are bound to cells in the vascular system, so that you get this explosive release of vasoactive products like histamine, and you become hypotensive, you can't breathe, you go unconscious, you're covered in urticaria, and of course there's a significant mortality. And adrenaline is you must treat these patients immediately with adrenaline and take them to a hospital.
Yeah, that makes sense. So we've got these mast cells, these IgE expressing mast cells all over the body. And if you get if you get the anaphylaxis causing agent to more of those cells, you're going to get more mass degranulation of mast cells, resulting in essentially a bolus dose of histamine. Yeah, that makes exactly a lot of sense.
The IgE
whereas if it's at a local if it's at a localized area, then you're only going to have a few mast cells there.
Yeah, but very quickly the antigen will spread, and even if it's not injected intravenously, inadvertently, then you will very quickly develop anaphylaxis. It makes sense that if you do inadvertently inject it into the bloodstream, you're more likely to get quicker and more severe anaphylaxis.
Yeah.
But you will get anaphylaxis even if it's absorbed just slowly in the muscle of the arm.
Mm-hmm. Yeah, that's good. I've just had another thought when we were talking about reverse transcriptase or the possibility of reverse transcriptase with the mRNA vaccines. But of course, the AstraZeneca vaccine, the Johnson & Johnson and the Oxford AstraZeneca vaccine, they were adenovirus vector vaccines. And they actually gave the DNA They were DNA vaccines. So do you think there's a possibility that the DNA in those could combine with the DNA in the nucleus without reverse transcriptase?
Well, it's a good question. I don't know the answer to that, but it certainly is theoretically possible. People have described long-lasting outcomes from the DNA vector vaccines. This is where you piggyback the DNA that would produce the antigen to the DNA of the virus, which is coming in to take over a cell. And as well as making the immune response to the virus, you, by the way, make an immune response to the piggyback bit of DNA, which will code for the spike protein. Theoretically, you should have the same outcome of that DNA as you do with the adenovirus DNA. It's, in fact, a friend of mine who I work with at McMaster University was the chap who developed the adenovirus vector system, and we were staying with it. He now lives in Rome, and I constantly joke that he must own castles now with his royalty rates that he must have got from
sure
his,
that's not true,
Robert. No, he says he just has a little farm.
Interesting idea, though, because I hadn't realised until this talk, really, that the
I don't know the answer.
DNA viruses the DNA from the DNA viruses could actually merge with my DNA and in my somatic cells. That hadn't quite clicked before. I'd assumed the DNA, the viral DNA in the human genome was as a result of reverse transcriptase. Well,
we know this occurs with, say, Epstein-Barr virus, and particularly into the B lymphocytes and the lining epithelial cells in the airways, upper airways. But we're getting adenoviruses and things like that all the time, and yet, to the best of my knowledge, and I'm not a virologist, we clear the cells containing the adenovirus, and we don't get integration of all of these to any extent into our human DNA. But of course, we know that it can occur with some DNA viruses, so why shouldn't it to some extent? It's sorry, I haven't really thought that one through very well, but
no, it's just me asking.
Sounds to me theoretically possible.
It's just my curiosity, imagination running wild. So in your article, Robert, you talk about the principle of first do no harm, but given that we have sophisticated treatments now and there is a bit of a risk of side effects, do you think this is a bit of an old-fashioned concept now?
No, I think it's the very basis of medicine. I think that throughout time, every medical intervention has had risk, and the basis of being a good doctor is to be able to work with your patient to understand the balance of advantage and risk. And every time you write a prescription for somebody, there's a potential of them having a side effect. That's a risk. But if it's, say, an antibiotic for pneumonia, the risk is heavily outweighed by the fact that you're going to get rid of the bacteria causing that pneumonia. And it's understanding the risk and working through that in a doctor-patient relationship that I think has become completely and absolutely bared. The first do no harm is linked to patient understanding and patient permission to give a treatment. And what we've got with the treatment of, and certainly the vaccination for COVID, is a circumstance which I think is unprecedented, where doctors are giving and pharmacists are giving vaccines to patients where they don't understand enough about the risk to explain that so that patients can make an informed choice. And that is, it's not first do no harm that's going out the window, it's the capacity for patients to give an informed choice to accepting a medication that I think is being challenged. Again, I'm not sure if I made that clear.
No, you have made it clear. I mean, what we're saying is we fanatically believe in first do no harm, and we also completely believe in informed patient consent.
I agree.
Not to have informed consent in any aspect of life is just completely unacceptable.
Yeah, I mean, it is not the role of a pharmaceutical company to make decisions for patients.
No. Two more questions that arise from your article, Robert. Has there been a change in doctor autonomy in the past few years?
By that, I suspect you mean can doctors still make the decisions, choices, communications that they did 20 or 30 years ago? Absolutely. It is so different. I talked to my grandson, who I'd love may well do medicine. After this, he probably won't be accepted by any medical school, but he would be entering into a very different medical environment to the one that I entered into. The structure of medicine has changed. When I graduated in medicine, senior role models in medicine would be the people who would teach me, the people who would provide me the ethical framework of how I worked, and the modus operandi of how I worked. Remember, ethics committees didn't exist, certainly in Australia, till really the 1990s. And so ethics were essentially your observation of your role models and the people who taught you. As Osler, the great physician at the turn of the earlier century, identified. And so now what we have are circumstances where decisions are being that should be made between a doctor and a patient are now being made by bureaucrats and people who have no understanding of the drug, and they're saying you can't use this drug for that disease. I gave you examples in another circumstance before. And as an immunologist, no two patients I see are the same. And so the decisions that are being made by the doctor are not something you can take from a randomised controlled trial because they don't exist for an unusual condition. You have to say, what is the process? You work this through with the patient and say, look, here is a drug that can do this. This is part of the chain of events that are causing your symptoms. Let's give this a trial for 6 weeks, maybe prednisone, a steroid, for 6 weeks or 4 weeks or 2 weeks. We can always stop it after 2 weeks. And let's see if it makes a difference. I don't know if it will or not. I think it might. And if the patient says, yes, that makes sense, then you do that. But that is now becoming very different. We can't do that in medicine anymore. So, yes, the autonomy of the doctor, I'm not saying autonomy by itself is the way it should be. You must have guidelines and you must have mechanisms to regulate and control medicine that is outside of those guidelines. But having said that, there's an intermediate zone that I think is sort of going or gone.
My last question is this. Are more modern, more expensive medicines always more effective than cheaper, older medicines?
Well, that's a very big question. And of course, you rapidly get into specifics.
It's a tongue-in-cheek question, of course.
Tongue-in-cheek. Look, the medicine is built up over many, many hundreds of years. And by trial and error, usually trial and error rather than understanding mechanisms, certain medications have become part of our lexicon. Colchicine, for example, is a very good example. Colchicine came from a plant. It was used in medicine when it was found to help people with gout. We now use it for a whole range of other conditions, from severe constipation through to familial Mediterranean fever. Now, that was not understood or known, but it was all found by trial and error and some level of science, sometimes more trial and error than science. So these medicines have found a place. Now, of course, modern science has transformed this. You walk into a rheumatology clinic 50 years ago and you trip over wheelchairs. You don't see wheelchairs in rheumatology clinics now. Modern medicine has come up with monoclonal antibodies that have transformed the outcome of rheumatoid disease. We're treating patients with inflammatory bowel disease with monoclonals, and we've got new tools that we can help. We're not seeing people with short bowel syndromes, where they'd have bits and pieces chopped out with Crohn's disease. I haven't seen that for years. Whereas when I started a clinic at McMaster University in inflammatory bowel disease, I can remember with horror, this increasing group of patients with hardly any bowel left because of progressive disease and large amounts taken out. So we're seeing wonderful things occurring in medicine, rare conditions, genetic conditions. So never ever let it be said that we're not making massive advances. But again, it gets back to this idea of balance. You don't throw out the older medications simply because they're old. You build on those and you splice into that system with good evidence and careful observation the new medications. I think the problem with the messenger RNA vaccines, and this is quite interesting, isn't it interesting that within 2 days, I just saw this the other day, within 2 days of the genome being identified, 2 companies got together and said, we're going to make messenger RNA vaccines, not ordinary just messenger RNA vaccines, and here we are, we're just about to start the phase 1 study. You really wonder who knew what and what was happening. Messenger RNA is a rogue example in modern medicine. It hasn't gone through the trials and errors and the safety checks that, say, the monoclonal antibodies have to go through. Now, you can say, it's because we had a pandemic, we had to make quick decisions. But we didn't have to take the messenger RNA route. The Chinese didn't take it. They took a very traditional route. And my reading is that the Chinese vaccines work just as well or badly as any of the messenger RNA ones. And good luck to them. There's certainly an Australian one that a friend of mine has developed, which wasn't allowed to be used in Australia because we had to use the American ones, and the Chinese, but it's being used in Iran, I understand, very effectively, or as effectively as any other. So it's difficult, isn't it? Very difficult.
Yep, but it's one that requires common sense and human adjudication. Yes. I think that the great test for us is how we now go on and handle the messenger RNA vaccine story, that we don't thrust ourselves into taking it for granted that we will spend billions of dollars making factories and all of a sudden all the vaccines are messenger RNA vaccines. That would be, to me, a calamity, until and unless we show that they're safe, that they don't reverse transcribe into DNA, that we have a system where it comes and it goes and doesn't persist systemically, leaving us open to essentially autoimmune disease. All of those things have to be sorted out in my humble view. I agree, and my mum would agree because she said never buy a pig in a poke.
Smart.
Never quite understood that, but the sentiment is accurate. Professor Robert Clancy, as always, thank you so much. You've answered all these questions you've answered, like loads. And all very well and quite fascinating. No, some of them were pretty hard. Plus a few I made up as I went along. So really appreciate it, Robert. Thank you as always, and look forward to talking to you again.
It's always a great pleasure, John. Thank you.
Thank you.